Hi everyone, my name is Austin. I'm here today to talk to you about mild traumatic brain injury, also known as MTBI. So what is MTBI? It's more commonly called a concussion. MTBI is just the medical terminology for it. This is a mild blow to the head with or without the loss of consciousness. This image here kind of describes how it works. What ends up happening is you get an initial blow to the skull, which causes damage to that part of the brain, or damage to wherever the brain connects with the skull. Then the head snaps and quickly snaps back to try to get back to a safe position. This is what we call the counter blow, because from quickly snapping back, the brain again crashes into the skull. So this is frequently sustained as a contact sport injury, such as a head-on-head collision in football or a boxer hitting another boxer, but it can be non-sports related. For instance, it's really common for slips and falls with an elderly population. For instance, my grandma took a spill down her basement steps about a month ago and hit one of the supporting beams that sits right next to her steps and really hurt herself. Along with car accidents as well, from hitting the airbag or hitting the windshield or what have you. So this leads to acute or temporary impairments in cognitive function as well as cervical spine function. Now, depending on how long these symptoms last, is really about their route of therapy, or even if they go through therapy. However, multiple concussions throughout your lifetime can actually lead to traumatic brain injury diagnosis, or TBI diagnosis. This is long-lasting effects, pretty much for the rest of your life. An example is chronic traumatic encephalopathy, or CTE. This became really popular with that movie Concussion, and the NFL basically is diagnosed post-mortem as a neurodegenerative disease. However, during a patient's lifetime, this kind of shows as dementia, which can really affect the brain and someone's life in a very negative way. So how do I know I had a concussion? So most patients can recall the specific moment of head trauma. It really varies from person to person, so this is kind of a generalized list. Seeing stars, that's pretty common. Just seeing those weird black spots in your vision after getting hit right away. Pain in the skull where the blow was delivered, that's pretty common. Nausea, you may not feel like you're going to throw up. You can throw up. That I've heard that of happening. But you can also just kind of feel nauseous. In the most serious cases, is a complete loss of consciousness. That can be for whatever extended period of time or a short period of time. It's also, patients can actually experience multiple subconcussive blows. I've worked at a PT clinic for just under a year now that specializes in concussions, and we've seen a lot of patients that, especially younger patients, that can't really recall a specific instance of head trauma, but for some reason have developed MTBI-like symptoms. Concussion syndrome. This is what we're actually treating in patients and clients that have MTBI. So these are symptoms that I experience. They're normally onset within like a couple weeks after trying to go back to activities of daily living. And these activities just become stressful on these systems kind of out of nowhere almost. So vestibular system, basically that just takes care of maintaining our balance, and impairment there causes obviously an inability to maintain balance, shakiness, swaying, and kind of that foggy-headed feeling. The ocular motor impairment kind of goes together with vestibular impairment. What ends up happening is the muscles in our eyes that normally dilate, contract our pupils, that move our gaze, control our gaze, steady our gaze on objects, become extremely stressed and sensitive to and creating headaches. And cervical spine instability, what ends up happening from the whiplash is the tears and small stabilizing muscles of our neck, which are really deep in our neck. And actually all these domains, they pretty much cause the same migraine-like headaches, dizziness, and nausea. However, you can experience one of these domains but not the other two, or all of them, or two or one, any combination. But really how they do it is the vestibular and ocular motor systems, they kind of work together. And it's simply actually just from those, for whatever reason, these systems become so sensitive to what their normal work is, and they just create really intense headaches. Ocular motor headaches normally kind of set in obviously around the eyes. Vestibular headaches kind of set in around the ears, or kind of like top of the head. Again, because our bony labyrinth kind of sits in our ear. However, the cervical spine instability is really and impairment is really interesting. What ends up happening is these small muscles in our neck don't really fully repair or re-strengthen themselves. So the sternocleidomastoid muscle, the SCM muscle, actually ends up doing the work of stability. So it's constantly contracting. It becomes extremely tight, especially on our mastoid process back here, which ends up creating these radiating migraine headaches back here. So what actually ends up happening is patients have to learn how to retrain these muscles to engage these deep neck muscles. So from this, patients can experience a lot of confusion. More seriously, this is more of a TBI and a long-term thing. They can have problems with their autonomic physiological controls. For instance, patients can just have a hard time regulating their heart rate or regulating their heart rate up and down. Let's say a patient's walking on a treadmill, which should seem relatively easy for them. Their heart rate spikes out of nowhere. We can sit them down, but they have a really hard time regulating their heart rate back down, or it takes a longer time than it normally should. Concussion screening. So this is normally done by a general physician, a sports physician, and then it's kind of reaffirmed again by a physical therapist at their evaluation. So basically, the very first broad thing that is done at a screening is the vestibular oculomotor reflex, or VOR. What ends up happening is if I keep my eye focused on the tip of this pen and move my head up and down, side to side, I can do that for a while. I mean, obviously anyone will get dizzy from it and kind of feel nauseous, but the idea is a concussion patient will experience this pretty quickly, almost within like 10 or 15 reps of that, either way. And that kind of helps us tell, okay, they have some kind of impairment. Now it's time to narrow it down. So balance assessment for our vestibular system. The double and single leg stance is kind of falling out of favor because obviously someone could already have crappy balance before they come in. What we'll do is like a walking forward, walking backward type test, heel to toe. But what's actually becoming really popular now is a baropodometry, or your biodex biosway. So what we have here is everyone has an amount of mean postural sway, which means if I stand with my feet together and my arms at my side, I'll have a little bit of sway in every direction. However, a concussion patient, they'll have a lot of exaggerated sway if they do have a vestibular impairment. What they end up doing is we do these tests on foam and a hard surface with their eyes open and eyes closed and compare these scores against norms. This is becoming a really helpful way to diagnose this. Gaze stabilization, this is for oculomotor stuff, smooth pursuits. So I should be able to, as a normal, someone without concussion, I should be able to focus on the tip of this pen, side to side, and my eyes really shouldn't get that stressed. Saccades are moving from two targets. So think about, moving from your laptop to something you're writing on the board. So moving from target to target, tip of the pen, and my eye should stop clean on that target. It shouldn't overshoot it or undershoot it. Near point of accommodation is how close something can get to my eye before it gets blurry. Someone with poor eyesight obviously is really isn't that helpful to test. However, near point of convergence is how our eyes work together to create new binocular vision. So as you can see here, I have the little image of good eye teaming. The image is clear. Poor eye teaming, you see how the image becomes kind of doubled. That can happen with this pen. If you imagine that if I'm getting too close to my face and I don't have good convergence, this pen's going to become doubled a lot farther away from my face. The normal point of convergence is about like 5 centimeters or so off the bridge of your nose. I've seen patients before that have like 10 to 15 centimeters off the bridge of the nose, and you can imagine reading something on your paper or your laptop right in front of you, and that's extremely doubled and out of it, double vision, and that creates a lot of headaches and even frustration. Case study. This is Jessica. She is a 20-year-old collegiate level soccer player. 8 weeks ago, she suffered a concussion due to a collision with another player head on. She was screened by her sports physician and followed by a physical therapist, confirmed. She had impairments in all 3 domains. She's about 6 weeks into her physical therapy. Rehab is pretty much centered around those screening tests that I actually showed you earlier. They really just become like an improvement resistance training type tool. So she still has some issues. She has light sensitivity, some neck discomfort, and a little bit of balance problem. Not awful. So she wants to really begin increasing her exercise and tolerance to return for weight training with her team. That's really what she's the most worried about. Her physical therapist has cleared her and recommended her to begin low to moderate exercise. So some of her vitals, her blood pressure is 120/60, resting heart rate 56 beats per minute, LDL and HDL levels 80 and 75 milligrams per deciliter respectively, BMI 20, fasting blood glucose 60 milligrams per deciliter. She lives a non-sedentary lifestyle. Obviously, she's an athlete, non-smoker, and her father had a heart attack at 53 years of age. So for her risk group, you put her at low risk. zero risk factors. The only thing that is a risk factor for her is the fact that her father had a serious had a heart attack before 55, and she actually has a negative risk factor because she has high HDL levels. So really her goals here are a little bit of basic cardiovascular reconditioning, really getting her muscles back to not really, strong, but not, it's mainly just for like reusing them, activation, and obviously maintain and gain some more flexibility. So really what we have to be careful with any kind of PCS patient or client is any of their balance issues. We want to keep them on mostly stationary things until they feel like they are improving. Their light sensitivity, their cervical instability, so we have to be careful with moving the head around too much or even actually doing a lot of neck stretches. Of any nausea and dizziness or other symptoms that can be brought about from exercise that actually comes from moving from exercise to rest too quickly, so we want to make sure they're cooling down correctly. Avoiding any risk for head injury. Obviously, I don't want them running around on the soccer field right away. And timing of training is actually really important. I found, especially with students, because she's a student, a lot of students that we saw, their symptoms would get really worse as the day went on because they were reading nonstop or doing other work throughout the day. So timing of training is important, especially and obviously after physical therapy as well. Physical therapy, they're really stressed. These symptoms are these impairment domains get very stressed because that's the idea, is to stress them so much that their tolerance to normal activities of daily living improves. So after physical therapy, they're very tired. So we have to think about their timing of training. I like to do it maybe more in the morning or on days where she doesn't have PT or even on the weekends. So for exercise testing, it's all sub-max exercise testing. Maximal exercise testing can kind of bring about all her different kinds of symptoms. I kind of list out some of the ones here. AMRAP push-ups, I might be a little bit wary of, only if she feels like she could do them. However, for exercise prescription, cardiovascular training, I'm going to lean more towards the 2 days per week. This really isn't her focus, and again, she's kind of already doing this. Actually, it's actually part of her PT. Normally, we warm them up with cardio anyway. So maybe 30 minutes, 40 to 60% of max heart rate. And again, doing exercise that really don't mess with her balance and don't really throw her up and down in up or down motion too much. So walking, stationary bike, row machine. And if she goes up to it, swimming kickboards with a lap. Swimming laps with a kickboard, sorry. And for resistance training, 3 days per week, this really should be your focus. 1 hour sessions, broken up into a split routine. So chest and triceps, back and biceps, legs and abs. 2 to 3 sets of 10 to 12 reps. We're in the hypertrophy range, really not too much physiological stress on the body. Starting with seated exercise machines and then progressing to seated free weight exercise, and really then moving to PVC form training for her compound lifts that she's going to be doing for all of her power exercises and weight training. PVC being literally a PVC pipe, I don't know, maybe weighs like 1 to 2 pounds. Just to get back to her form training, to get her comfortable with those movements again before she goes back and works with her team. Finally, flexibility, 3 days a week right after her sessions. Weight training, 15 to 20 minutes. We're going to stretch the mild discomfort over 30 to 45 seconds and 2 times per stretch, multi-joint stretching. And we really want to avoid anything that's going to move the neck around too much. And then we want to be able to progress to more advanced like yoga-type stretches. So just some closing thoughts. What's really important to think about is there's this idea of complete rest, and it kind of ties up with my next point of fear avoidance, that, in order to get over concussion, you have to completely rest. But what ends up happening is it really doesn't help. The idea is that we need to stress these 3 impairment domains in order for you to get better. Because if you think about it in the terms of resistance training, your legs get stronger, you can handle a lighter weight easier squatting. That's the same kind of idea with these impairments. So we don't want people sitting around for months on end hoping their concussion gets better, because it probably won't. This kind of comes again with the my little joke here out of the NFL, who has a really crappy concussion protocol. It's really well known now that in acute PCS patients, meaning a couple weeks after their concussion, exercise actually aggravates their symptoms. And from seeing a couple ex-football players that the PT I work for saw, the protocol basically they had them move from different stages of aerobic exercise, which it doesn't make any sense. They couldn't get past the second or third stages sometimes because the aerobic exercise would onset their symptoms anyway. So it's really important to integrate physical therapy into rehabbing for concussion syndrome or PCS. Otherwise, you're not going to get someone back to where they should be. And here are my references. So hope you guys enjoy my presentation.